Hey everybody, day 2, Hint Summit. Still see a lot of smiling, fresh faces out there. I think everyone was a little tired yesterday and I can feel the excitement again today. So I'm really excited to be up here with the supporting cast of Direct Care. We have some really exciting people doing exciting things that round out Direct Care. Direct primary care is the foundation of Direct Care. You can't have direct specialty care, in my opinion, without having that primary care touch point first. But most of you are already working with direct care partners in your space, whether they identify as direct care or not, because you're finding the lowest cost options for your patients. You're working with employers to find direct imaging, direct specialty, direct lab. So these companies are working to make it easier for you to do that. So we're gonna have a conversation today about how these folks work with DPCs, how we can partner to work with employers, and just learn more about what they're doing. So I'm gonna let them introduce themselves and their companies, and we'll hear about their journeys as well. Sandy, do you wanna go ahead?
Hi, we're Decent. So many of you know Nick Soman already. He's over there, and you can bother him if I don't give you substantive answers about anything that I'm going to talk about today. You know he can talk, if you know him at all.
We had to kick him off this panel.
We build employer-sponsored health plans around the DPC, and the problem that we're trying to solve for you is allowing you to focus on caring for your patients and allowing patients to focus on being cared for and taking care of some of the things like payment, so that you don't have to deal with those distractions. So we're really focused on that supporting that DPC member relationship and taking care of some of the distraction there. So that's what we do.
Thanks, Sandy. Lisa?
Hi, yes, my name is Lisa Fagan. I'm the CEO of Smith Medical Direct Specialty Care Surgery Center here in Colorado. We are direct care of your surgical needs for a bundled, fair, transparent pricing. Our top goal is to deliver high quality care and put the patient first. We're here to support the DPC community and be able to ensure congruent care through the whole process.
Hey everybody, Sidney Haitoff, co-founder and CEO of Mishi, not Mish, Mishi. I know it's hard to, can't tell from the name. And just to give you a sense, Mishi is a short for Misha Bayrock. It's a prayer for healing. So we're trying to heal our broken healthcare system, starting with payments infrastructure. We built a software platform that enables a free market in healthcare to catalyze the direct care ecosystem and movement. And what that means is we're combining direct care with direct contracting, direct adjudication, direct payment, and creating a closed loop infrastructure that integrates the entire supply chain and care continuum to simplify transactions, improve quality, and reduce cost. Happy to be here. This is an amazing venue, and looking forward to the talk.
Yeah. So Sidney, starting with you, most DPCs have these direct relationships in their community. They're one-on-one. How does an entity like Mishi help, scale that, or help DPCs on a very practical basis to work with other direct partners in their community?
Yeah, so direct primary care is an ecosystem of innovators, right? Direct primary care docs were the first ones to pioneer direct care, and the rest of the ecosystem is starting to follow suit, thankfully. Smith Medical is a perfect example of that on the clinical side with the direct specialty care. But most other docs and facilities, et cetera, aren't as familiar with the ecosystem and don't have the tools to engage in the ecosystem. And so what we've built is a mechanism, a platform, and also a network, legal infrastructure that allows for specialists, hospitals, ambulatory surgery centers to engage in the direct care movement, but in a scaled way. rewired the adjudication infrastructure to automate claims in a way that you would expect from a traditional TPA, but in reality, we're automating claims so docs don't have to worry about the billing process in the same way that direct primary care was started to address. And so making it easier for the broader ecosystem to tap into the benefits of direct care and integrate with direct primary care so that the direct primary care docs can access specialists and the broader ecosystem in an integrated way and go beyond their referral partners that they have.
You know, I think it's interesting what you say about the integration into the ecosystem and the unfamiliarity there, because we see that in the distribution ecosystem too. So DPC is new on the front end in the distribution ecosystem, and that brokers aren't necessarily familiar with it either. And so we do best when we find brokers that are friendly to the DPC model. They know what it is. They're familiar with it, they've sold it before, and we're able to pair a friendly, knowledgeable broker with a DPC. And you've never seen an onboarding meeting go so well with an employer group as when you bring in a DPC and you say, hey, this group in Kansas that we recently onboarded, whose name I'll leave out for obvious reasons, this is your new doctor. This is who you're going to work with. We're not just introducing you to your, faceless plan whose benefits that you're expected not to use because they're prohibitively expensive. We want you to use and see this doctor who actually cares about you and wants you to engage.
Lisa, tell us about the role of Smith Surgery Centers in the direct care space and how you envision working with direct primary care.
Yeah. Direct primary care is kind of the gatekeeper of the patients, right? So they are getting a relationship with the patients feel comfortable with them. So when they're like, hey, you need a surgery, this is a great place to go, they already have a strong relationship, right? So they feel comfortable being like, okay, and then they come to us and they meet one of our patient coordinators, which is very different from a typical surgery center where the doctor will just put the surgery on, and then we don't really talk to them all that much, right? So we have a relationship with the DPC where they refer the patients to us. We then gain a relationship with them, send them to the physician, and we continue the care where if the physician's like, yes, they need surgery, then we send them back to their DPC to get checked off for surgery, and we continue the relationship. So the patient feels very comfortable coming to our facility, and all the surgeons and the DPC are in communication, which is wonderful.
And are you also enabling the billing and the administration with, I'm assuming employers, I want to get into employers next because I think you're all employer focused. So how does that work?
Yeah, with our patients?
With your patients, with the DPC, with who's typically paying for the surgery?
It depends on, of course, where they're coming from. If they're coming in from a self-funded employer, the employer is paying, and most of the time we already have contracts. They know exactly what our pricing is. Like he was saying, our pricing is posted. So you can literally go on our website right now and say, oh, I have a broken clavicle, it's gonna be this price. No hidden fees, completely bundled, transparent pricing. So it's not, you don't get a bill from the physician, you don't get a bill from anesthesia, you get one bill. So patients really appreciate that. For DPCs, it's great because they can say, okay, do you have insurance or who are you working with? Are you working with Zero Card or Savos? So they know what they're getting right before they're coming in. It's no hidden fees whatsoever.
Yeah. So what do you see as some of the challenges for expanding the ecosystem of direct care? I know you're trying to solve it directly. Sidney?
Yeah, I'll address that. One big problem for providers outside of the direct primary care ecosystem are the restrictions against transacting at discounted cash prices. So, discounting services off of the charge master is prohibited by anti-Stark or Stark and anti-kickback statute, and also some state regulations. Texas deems it a misdemeanor offense if you charge a different price to one person versus another based on their insurance status. Those rules were put in place to protect the legacy carriers and the old payer. Employers have become the largest payer segment in healthcare, outseating the carriers, but we're still dealing with the legacy infrastructure, not only with regards to the transactional infrastructure, but also the regulatory infrastructure. What I think we are working to do to Michi is working to do to overcome that is we built a network. Networks are the only legal mechanism through which services can be discounted off the charge master. And so out of necessity, we built one, but we're the first transparent network. We're incentivized to post our prices transparently, and we've powered the first hospital to post their transparent discount prices publicly so that members can purchase anything from a inpatient procedure, outpatient, et cetera. The point there is that it's up to innovators like us to continue to create these tools that allow for the broader ecosystem to connect and to enrich the direct primary care offering. And so, yeah, I think the regulatory issue is a big one. It's been great to see, bundled care and value-based care bundles, value-based care offerings outside of the direct primary care ecosystem that helps offset and skirt some of those regulations, but we're looking forward to scaling that even more.
So we work through high-performance networks, direct contracts, bundled pricing. I think once in a while we run into kind of the thugs of the facility world, right? That children's hospital that just doesn't want to play ball, and somebody really, really wants to use. That doesn't, necessarily want to be transparent, that doesn't want to, offer a cash price that we could prepay, that doesn't want to, sign a direct contract. And so those areas are sometimes infrequent but sticky, right? And those are, they're places that we need to work through for, specific members at times.
And how do you do that?
I think it can be difficult. It's a case-by-case basis in a geographic location basis. I would say, like many other things in this system, as we've been talking about over the past couple of days, sometimes it comes down to relationships. And we can often work those channels to get things done.
Yeah. Lisa, what are you seeing as the biggest challenges actually being a direct care provider in the market?
I think it's education of everybody's been told forever, insurance. And so people have high deductible plans where we can actually save them money by coming to Smith and, thousands of dollars. But nobody thinks about looking that direction at first. So I think the education of what's out there, what we can offer and how we can save them money.
Yeah. Have you seen a shift in the winds in employers' willingness to direct contract? I know it's been in every headline from Benefits Pro is direct contracting is blowing up. And I feel with direct primary care, there are more and more people hearing about it inbounding rather than us having to explain the story. So do you feel like that shift is happening, or do you feel like we're on the precipice? Like, where do you think we're at in terms of market adoption of direct care outside of primary care?
I'll take that. As someone who was yelling and screaming on LinkedIn 2 and 3 years ago about cash prices outside of primary care, and that was a novel and almost taboo topic, to now it being the norm and people creating and offering health plans around that paradigm, I think it's definitely we're hitting an inflection point. I think Dave Chase said that we're getting to the end of the beginning, or the beginning of the end, I forget which one, but the point is that we're coming to the inflection point where, I think that people understand that the way that things are and have been, these year-over-year increases in premiums, 20% year-over-year with no checks and balances in place, they're seeing that there has to be another way. And given the dynamics of direct primary care and direct care, where we're all facilitating direct access to your doctor and eliminating the middleman. You know, some of us in different ways than others. We're replacing men with middleware. You guys are facilitating that relationship and using those relationships to create that direct access. I think that makes sense to people, and the pain is enough to where they're looking for options, and it's good that we're here to provide them.
And I think on the patient side, the patients really enjoy it, right? Because they're not paying anything for the surgeries that they're coming in. So when I'm talking to these patients, they're like, this is the way healthcare needs to move. This is awesome. I'm going to go back and tell everyone we have this. Because a lot of people just don't even know, right, what's out there, like I said before. And I think like through Zero Card or Savos or Coral, these patients are coming in and they're like, I'm actually taking care of myself. I needed this surgery years ago, but I'm finally doing it because my employer's paying for the whole thing. Yeah.
So it's really interesting. Decent currently has one plan. It's the Decent Zero plan, and it's care directed through your DPC, and if you do what your DP says, that care is free. I think there's a question there around the value of going to see anybody, right? And the value of having this broad, wide network. I think that what we're discovering is that members don't care as much about having access to anybody in the world. What they want is quality care. And so that's where the direct contract becomes really valuable, right? And that's where we're seeing, as Sidney mentioned, kind of this inflection point with maybe I don't need to see anybody, I need to see who's important.
Yeah. I'm glad that you brought up value, because I think that with direct primary care, it's all about value. Like what Dr. Cameron and Dr. Workman said, like they can keep increasing their prices, and they're finding that people will pay for it because it is value, and value is so scarce in our American healthcare system right now. Prices are so high, and the experience and quality is so low. And a question I often get with about direct primary care or direct specialty care is, how do you measure quality? Because employers are so used to getting quality scores for everything from insurance companies. They're rarely acted on, but it's a question that I'm sure you're all posed. Like when you're doing these direct contracts, how do you know it's not someone who just put out the lowest price and you're actually ensuring that enhanced experience, a guided experience, better outcomes with that direct price?
I'll start. I'm pretty open about my thoughts around quality measures and legacy quality measures. I cut my teeth on the physician quality reporting system when I entered the space about 10 years ago, which is now macro MIPS. Claims-based reporting is a joke. It's a farce. And for the most part, it's an accurate and incomplete representation of quality. I think those measures that employers get through their legacy insurers, they don't look at them because they're, I don't want to say fake, but they're not meaningful. I think that we as a collective group are perfectly positioned to implement real quality measures. You all as DPC docs and us in the community who actually care about patients and not generating profits hand over fist, we're the ones who are incentivized to drive and create a new paradigm of quality based on new quality measures that actually are based on care and not just did you go back to the hospital, readmission being a big quality measure, or did you have a revision? There are lots that goes into whether a doc had a large number of revisions or not. Point is that the quality metrics that are available, and most of them aren't for specialty care, right? They're created for primary care. There's an opportunity there to create a new set and a new expectation, a new baseline for quality. And so, looking forward to working with you guys in creating that. But yeah.
Yeah, I agree with Sidney. I think that we all, like at every surgery center I've ever worked at, we're collecting infection rate and all of the typical quality measures. At our surgery center, we're going to be sending out surveys to every patient like the DPC community does and be asking them different questions like, How long did the doctor spend time with you? Did they follow up with you? How comfortable were you with them? And then also asking the employees that work with the doctors, right? Like, how nice are they in the ORs? Like, how are they treating you? And because we are cutting out the middleman, we're able to pay the physician at a higher rate than insurance companies. And so doctors want to work with us, which is wonderful. And so if they're not producing good quality, we'll stop referring patients.
Great. So I wanted to ask you a final question. How do you want to work with direct primary care? How do you see the role of direct primary care providers in advancing and participating in the larger direct care ecosystem, going forward?
So we are nothing without our DPCs. We are a health plan built around you. We have a lot of baggage as a health plan, and I think we recognize that. I hate saying the words health plan. I realize that we have a lot of work to undo in this space. I think I didn't like the name decent when I joined the company. I thought decent, it sounds mediocre, right? It sounds just good enough. I thought, what am I inheriting from a marketing perspective? But I've come to love it because it means decent people, great coverage, decent people. And I think we're really committed to that. But we need to support you. And I really see us in a deep listening, active listening support role. So I would encourage you to reach out directly to me. I know many of you have spoken to Nick, but I would like to speak with you. We need to learn how to better support you because that's what we're trying to do in this space. We want to involve you more deeply in that relationship with your members, and we want to support it.
With surgery, you always need primary care, right? So direct primary care, it works congruently together. We're able to take care of the patient, the full picture of the patient. We're able to treat them as a whole, not just come in for surgery and then never see you again, right? So we also are nowhere without the DPC community.
Primary care is the front door of not just health plans, but health care. I think that a lot of conditions and most conditions, most ailments, most issues that anyone experiences throughout the course of living can be addressed by primary care docs and should be addressed by primary care docs without having to go to the ER. I think the reason why people result to going to the ER is because the primary care ecosystem has eroded because of how difficult the legacy infrastructure has made it, the legacy plans have made it for primary care docs to keep their practices open. Declining reimbursement, increased admin burden, PQRS if you're gonna, and MIPS if you're gonna be a Medicare provider. Like, I don't blame you for dropping the old world because it sucks. And I commend you for going out on your own. It's up to us to help drive demand for your services, right? That's why these carriers have such a stronghold on our industry, is because they control the demand. They control the relationships with the employers, with the brokers. Not all of them, obviously. There are some that are here. Kudos to you guys and gals, but some that are changing the paradigm. But it's up to us as a collective to change the way that the broader public interacts with healthcare. Like you said, everyone is accustomed to going through their insurance. And that's a function of the insurance carriers diminishing the value of primary care because they want to increase the utilization across the specialists because of the ACA and medical loss ratios limiting their profit margin, so they have to increase the price. So they don't want people going to primary care anymore because that's against their revenue generating function or system. And so I think it all comes down to, one, driving more demand for direct primary care because direct primary care drives value for the health plan. savings for the health plan. And I think it also comes down to facilitating more collaboration across the broader ecosystem. And I think the legacy infrastructure has faxes and has barely started using technology. I think that this ecosystem has a perfect opportunity to introduce not only a new paradigm with regards to health plan infrastructure, but a new paradigm with regards to technological infrastructure. That's what we're here to help with. And it's up to all of us to help you guys, because it all starts with you.
I'd love to open it up to questions now. We have a few minutes left. So do we have any questions in the audience for our panel members? We have 1, 2, 3, 4. We're going to get our mic runner coming to you.
They're all in the back.
Yeah, I know. I'm sorry, Alex.
We love you, even if you're sitting in the back.
Hi there. My name's Katie Dumont. I'm in a DPC practice in Cincinnati, Ohio. And we were just talking, my other doctor and I were talking, we have a really hard time finding specialists. Like, how do you bring that culture into a city like Cincinnati that is so employed, or huge insurance based?
Yeah, absolutely. We have some great ways of doing that. We employ an in-house care navigation team. In fact, our care navigation lead, Julia Kolf, is sitting right in the front row right here. I can introduce you. We look for the best high performance, high quality, low cost specialists that we can help pair our DPCs with when they have a gap. We first look to use whoever DPCs prefer and make that care free to our members who are working with the DPC. But if there's a gap there, you can work with Julia and her team, and we can refer your patient to someone that Julia and her team might recommend. And that's how we solve that problem.
Yeah, second that. Amen to care navigators. They bridge the gap. They're the connective tissue. We also have a care navigation team. They're going out, finding docs, specialists. And the beauty is that they can be specialists who take insurance, right? As long as you provide them with the right infrastructure, direct contracting, but also, a network that they can then access, not only demand from you as a DPC doc, but maybe that would invite other DPC docs to enter the ecosystem in your area. The more that we're able to facilitate those connections in a way that doesn't concern the specialists and their ability to participate, the better.
I would also really recommend tools that are geared toward direct pay for consumers, like Asabos and MD Save. They have lists and directories of specialists that will take direct pay. And so those would be good folks to reach out to in your community and say, hey, I'm direct primary care. Do you want to come see my clinic? Develop a relationship, because they're already putting themselves out there on other platforms saying that they'll go out around the system. That's in
Miss you too, in case that wasn't clear.
Yeah. Savos, MD Save, Mishi, Tendo, MD Save, yep. Aaron?
Hi, I'm a benefits advisor in Cleveland, Ohio. So we're just going to take questions from people from Ohio. My question could be for the entire panel. I'm interested in what you see going forward as the ideal patient journey from a DPC visit to getting the specialty care. Because just putting in place who's on the stage doesn't actually make the member journey seamless. That, as a benefit advisor, what I'm really challenged to do as I put DPC and direct contracts in, which I do have, I would love to just hear what you think that would be and just explain ideally how that goes.
Yeah, so, sorry, I know we're all chomping at the bit to answer this question, but when I say that we build technology, a software platform to integrate the ecosystem, it comes down to the referral as part of it. Yes, we have a navigation engine that you can see, all of the docs that are in your plan for each of the plans that we have, a dedicated environment, but we have an integrated referral management mechanism that allows for primary care to make the referral from the system into their group of direct contracted specialists in their area. If there are no direct contracted specialists, they could make the request and the referral, and we'll go find them. The point is that at the time of referral, the member is getting a text message to notify them of their order. The receiving provider is getting a text message to notify them of the referral of the order. And at the same time, the funds for that particular consult to a specialist are being pulled from the claims fund bank account, held in our escrow, and then that goes to the specialist after services are provided, so that the member doesn't have to come out of pocket. They don't have to pull their member ID card out of their pocket. They know exactly where they're going, what service was rendered, and what it's going to look like to receive care. And so, yeah, eliminating all surprises for members, I think, is what it comes down to.
I apologize, but we have to wrap up. We're at time. So you're going to have to find these guys at lunch and ask them your questions. But thank you so much for being on this panel. It's a really important topic. So find them at lunch.
All right, let's stand and give them all a round of applause.